who have comorbid conditions, those patients can present to us like that. Then there are patients who are on multiple antipsychotics and antidepressants, who may have drug interactions, who are on polypharmacy. So these are patients who can come with features of overdose without actually overdosing on tricyclic antidepressants. Secondly, the onset of tricyclic antidepressant overdose can progress very fast. A patient who looks normal to us at presentation may deteriorate very fast within an hour itself. And lastly, we emergency physicians depend a lot on the ECG for managing every patient. Here, ECG becomes our most important tool to stratify the risk and for assessing and managing these patients. While everyone is joining, I would like those who have already joined to go through this case scenario of a 26-year-old patient who was brought in unconscious state after being found in her bedroom. There were some empty medical strips found near her bed, and the ingestion was approximated to be 2 hours. Her initial assessment suggested a GCS of E2V2M5. She was tachycardic, she was hypotensive, her respiratory rate was 10, and she was maintaining saturation at 95% on room air. Her temperature was 38.2 degrees at presentation. On further examination, her pupils were 6 mm sluggish. Her skin was warm and flushed. There was dry mucosa, decreased bowel sounds. Her bladder felt distended, and there was no focal neurological deficit. You can see the ECG here of this particular patient, and you can also look at the initial blood gas that the patient presented with. After 10 minutes, the patient further deteriorated with these features. I would like everyone to take 2 minutes and try to answer the questions that are there. You can answer them in a paper nearby, or you can put it in the chat. We will visit this case once we are done with today's session. I hope everyone has captured a bit of whatever is there in this picture. I'm sure that you have answered the first question because of the topic, but most of the times we don't know what poison is going to come to us, and this could be the initial presentation of the patient. So we need to answer all the questions that are there. So this is for everyone's learning. You can just note down and keep. Now that 2 minutes are done, let's move to the main content of today's session. So whenever we are dealing with any patient in the emergency department, irrespective of the etiology, we have to assess and resuscitate the patient first, and we diagnose in parallel. So here also, we start with the airway and protect and secure it if the patient requires airway intervention. For example, in such patients, they may be comatose or seizing. There, the patient's airway need to be optimized. We assess for breathing look for hypoventilation and signs of hypoxia, and address them as required. These patients can come to us in shock. They will have arrhythmias. So we have to look at circulation, get our IV accesses, attach the patient to cardiac monitors. We initiate fluids if they are in shock. We assess for disability. It will help us guide in the assessment in appropriate primary intervention, and also hint towards the toxidrome or the possible toxins that are present. And we always look at the skin, the temperature, and for any traces of any drugs present on the body when we expose the patient completely. On simultaneously, a focused toxicological history is important. Here, if we are talking about TCAs, then we should know which TCA, because each of the tricyclic antidepressants, depending upon their structure, act on different systems differently. Some are more cardiotoxic, while some are very have a higher seizure potential. So this will help us guide and think about our treatment plan before we even see the manifestations. We always need to know how much, whatever drug it is. We need to know the time of ingestion and the time that has passed since then. If there were any co-ingestions involved, that is an important history, because many a times our toxidrome may be masked. The patient may present not patient may present in a different with a different constellation of symptoms, and also some co-ingestions may be such who have antidotes. So it is always important to take care that we take this history of any possible co-ingestions. We talk about whatever symptoms the patient had before coming to the ED, and any other thing which you may think is important for that particular patient. Medico-legally, it's important to note where this happened, when it happened, whether it was witnessed or not. These are specifics that you take for medico-legal purposes of documentation. Before moving to the clinical features, it is important that we identify and understand the mechanism of tricyclic antidepressants in toxicity. So, see, tricyclic antidepressants work at many levels. We'll talk about the serotonin receptor level first. So, the primary role of tricyclic antidepressants is to prevent the reuptake of serotonin. So by doing that, it increases serotonin in the cleft, and hence they act on the 5-HT receptors. Similarly, it has an action on the norepinephrine receptors, where where it inhibits the reuptake of norepinephrine. Now, this mechanism is where its therapeutic role is. This is how it acts as an antidepressant. All the other ways in which tricyclic antidepressants act on the body do not have a therapeutic effect. So other features which tricyclic antidepressants have is they act at the histaminic postsynaptic receptors also, and cause blockade at the H1 receptor levels. They also cause blockade at the muscarinic receptor levels. And for alpha adrenergic receptors, it's important to know that there are two ways. See, we have seen that norepinephrine reuptake is blocked by tricyclic antidepressants. So here what is happening is norepinephrine is increasing. So this will be somewhere sympathomimetic effect. But here it also has a blockade effect on alpha 2 receptors and alpha 1 receptors, which will cause your reverse sympatholytic effect. So here you may get to see features of both. However, these features will predominate only in the overdose condition. It also acts on the GABA receptors and reduces the seizure threshold. What is most important in this is the key mechanism by which it acts as the cardiac toxin. So here it acts on the sodium channel, where it will bind to the sodium channel and let the sodium channel be open. So by this, what happens is it acts on your normal action potential. When the sodium channel is blocked, so what will happen is your phase 0 will slow. When this is slowed, because of the sodium channel blockade. The slope you see in the normal is upslope straight. Here the slope has increased. So this here it acts on the phase 0 and increases the time of phase 0. Okay. Then it also acts on the potassium channels and increases your plateau phase also. And by increasing these two, what happens is your total refractory period will increase. And because of these things, what happens is a conduction velocity will reduce, the automaticity of the heart will reduce. This will also reduce your myocardial contractility and cause all kinds of arrhythmias. Here, what is important to know is this also, that we know that it's mainly sodium channel blocking agent, but it also has its action on potassium channel, which causes your QT prolongation in these patients. It may also cause QT prolongation in these patients. So we get a lot of arrhythmias. We can get a lot of arrhythmias in these patients. After understanding the overall mechanism, it is also necessary that we know that the tricyclic antidepressants are called so because of the presence of these connected three rings. And they are divided into secondary or tertiary amines depending upon what chain is attached there. So here you can see that these are your secondary amines which have one single NH bond, which is one bond is free over here. Over here, there is no NH bond and there are two amine groups. So this is your tertiary amines. Depending upon these structures, the tricyclic antidepressants belonging to each of these classes can have different effects. So if you look at tertiary amines, what happens is they have a greater effect of inhibition on serotonin receptor uptake and compared to the norepinephrine receptor uptake. So their features will have more of serotonergic symptoms. In addition to that, they also have a higher effect on the cholinergic blockade. So the anticholinergic features also in patients with tertiary amine overdose will be much more. Even not in overdose, whenever you're prescribing a patient a tertiary amine, they may have sedative effect because of their H1 the H1 inhibition. They may show symptoms of anticholinergic effects because of their potent effect on these areas, and that is all because of how these rings are present in these amines. The tertiary amines are the most cardiotoxic ones. So it is important that we know this. And you know that amitriptyline is one of the commonest drug that is prescribed. So it is important that we are aware about which toxic effect will be seen more with which kind of tricyclic antidepressants. For secondary amines, it is seen that norepinephrine inhibition, uptake inhibition is more compared to serotonin. And these do not have so much of an effect on the on the cholinergic blockade or the histaminic blockade. So they have less sedating effects and they are better tolerated even with the patients. Overall, cardiotoxicity is low in these patients, but desperamine is the most cardiotoxic tricyclic antidepressant. In addition to tricyclic antidepressants, there are two specific antidepressants which also have been put in this group, but in actuality they are not tricyclic, they have tetracyclic, they have four rings basically. So meprotylin and amoxapine are two exceptional uh, antidepressants which are categorized in the tricyclic antidepressants. Amoxapine, though it has a three directly linked three links, you will see that there is a difference in the amine group down the. So here, because of the presence of this ring, what amoxapine has special capacity is to act on dopamine receptors also. So by blocking dopamine receptors, it has some antipsychotic properties when we are talking about its role in therapeutics. But this also has a problem as they by acting on dopamine receptor, it will also, reduce the seizure threshold. So these patients can present with seizures even with a normal ECG without the initial cardiac toxicity features presenting. For maprotilene also, these drugs also have a higher seizure risk, though cardiotoxicity is similar to the others. By understanding the mechanism of action, it is very easy to actually list down the clinical features. So the commonest clinical features these patients may present with are coma, and the coma will be very rapid. Within an hour, you may see a normal patient becoming comatose. Patients may present to you with seizures. Sometimes they are early, and presence of seizures help in predicting the severity of the disease. Next, they can come with cardiac toxicity signs, which may initially be present only in the form of ECG changes, or it can be in the form of lethal arrhythmias, or the patient may present to us with hypotension. But these are the main features. However, we have to remember all the mechanisms by which TCAs act on the body. So we may find a lot of other features also. We may find anticholinergic toxidrome, where you get dilated pupils, dry mouth, flushed skin, urinary retention, decreased bowel sounds. The patient may be confused or agitated. The patient is, dry, is hyperthermic, hypertensive. In these patients, we have this one little thing, that these patients may be hypertensive but not very hypertensive. So this may be a small differentiator or small pointer towards something other than an anticholinergic toxidrome. The patient can also present to you with features of depression, CNS depression, due to H1 effect, H1 blocking effect. The patient may present to us with hypotension because of its sodium channel blocking effect, because of its alpha receptor blocking effect at the peripheries. The patient can come to us with proper sympathomimetic toxidrome like features also. So in all of this, it may sometimes be confusing for us in the emergency department to come to a conclusion that what was the drug that caused these symptoms if we do not have the drug. The core managed diagnosis lies on four pillars mainly. First is the history of exposure. If we have the history of exposure, yes, life becomes easy for us in the ED, but all emergency physicians here know how frequently we actually get history of which drug the patient actually took. Then coming to the clinical symptomatology. These patients can present to us with a mix of toxidromes, and clinical symptomatology may not always guide us towards a correct thing. But yes, we need to know that a lot of findings can happen in these patients. Next comes your positive urine drug screening. So here there are two problems. One, that many of the institutes still do not have urine drug screening for tricyclic antidepressants. Suppose we do have, then there are too many false positives associated with these tricyclic antidepressant overdose. Simple examples include cetirizine, which is a common drug taken very frequently by nearly every one of us also, let alone the patients. And carbamazepine, which is also a common anti-epileptic, which is given or for pain management. Your patient may be on these drugs and test positive for urine drug screening. So a positive urine screening can support our diagnosis. It cannot define the severity. It cannot exclude anything else for sure. So what is left with us is the ECG, which can be diagnostic, which can help identify the severity of the toxicity and guide the management also. So there are many ECG findings that you can find in tricyclic antidepressant overdose. Coming to the commonest and the simplest, which is sinus tachycardia. So about 70% of our patients will present to us with simply sinus tachycardia, and with some of the features that we discussed before. Now coming to specifics, you may find wide QRS because of the sodium channel blocking effect and the action increase in the duration of your action potential. So you may find a wide QRS complex. A wide QRS complex duration can help in identifying certain high risk situations, which we will be discussing soon. We may find increased, as you can see, it can progressively increase with the time and with the amount of toxin ingested. Sometimes what we may find is a terminal R wave in AVR. I will show this better picture in the next ECG. We may find features of right bundle branch block. One of them, is an R by S ratio of more than zero point 0.7 in AVR. We may find right axis deviation signs. And here, what is more specific is that the terminal 40 seconds of the QRS complex will have an axis of more than 100 to 120 degrees. And this is because of the delayed conduction that happens due to the blockade. We may find a prolonged QTC. This, we have to remember, is not due to the sodium channel blocking action, but due to the potassium channel blocking action. And interestingly, if your patient presents to us in sinus tachycardia, it kind of has a protective effect from this prolonged QT. So if the patient is having sinus tachycardia, he may not develop arrhythmias due to prolonged QTC. So other features that we may get is any kind of block, first degree AV block, or any degree of heart block per se. We may find other features of right bundle branch block, as in your RSR dash pattern. 10 to 15% patients may show us the Brugada-like pattern. The patient can present to you in BT or VF, the mechanisms we've discussed further earlier. And when these durations, every duration prolongs in, TCA overdose, PRP, QRS. So it may show you a sine wave pattern like hyperkalemia also. So we have to keep everything in mind that all of these can be the ECG findings in tricyclic antidepressant overdose. The most important, I think, is your QRS duration. A duration of less than 100 milliseconds suggests a low risk, even if the patient gives a history of tricyclic antidepressant overdose. Those patients who have a longer QRS of more than 100 milliseconds, they also have an increased seizure risk, except amoxicillin, where you may not get any QRS prolongation, but the patient always has a higher seizure risk. Those who have a QRS duration of more than 160 milliseconds are at a higher risk for developing BT. Presence of R wave. Initially, it may so happen that we do not get your QRS duration prolongation, but there is an R wave of more than 3 mm in AVR, and you do not have a direct history that it's TCA that the patient has consumed, but you know that there's a possibility of a toxin, then we must think of tricyclic antidepressants as the source of the toxin. So if you look at this ECG, you can look at the AVR and you find that the terminal part is the terminal R, and if we could measure it, it would be more than 3 mm. And you can also appreciate that the QRS duration is long in this particular ECG. After coming to a clinical diagnosis, we move to manage this patient. So we have already talked about resuscitation. Now we move to specifics related to toxins. So we talk about GI decontamination. Single dose activated charcoal of 1 gram per kg in a patient who is awake, has a patent airway, and arrives within 1 hour of ingestion can be considered. However, if your patient is comatose or is vomiting or is having excessive secretions or has come to you after 1 hour, then even single dose activated charcoal may not help us much. There is no role of gastric lavage. There is no role of multi-dose activated charcoal or whole bowel irrigation in these patients. The antidote we can consider in this situation is soda bicarb. So sodium bicarbonate raises your sodium gradient and it reverses the block. The indications is important that QRS duration of more than 100 milliseconds, presence of any arrhythmia, presence of refractory hypotension. That is the time when we need to consider giving sodium bicarbonate to these patients. The initial bolus is given as 1 to 2 milliequivalent per kg and then repeated. The details I will be discussing in the next slide. What is to be kept in mind if the patient has come to us with these features is avoidance of any other antiarrhythmics. We can't give class 1A, 1C. They will prolong the sodium channel blocking. They will worsen the sodium channel blocking effect. 2, 3, and 4 also will have your effect on the AV node, on the potassium channels, and these drugs also will prolong the toxicity of the TCA or worsen the toxicity for that matter. Now, there are two drugs which are discussed as an option when sodium bicarbonate is not able to revert your arrhythmias. One is lignocaine and one is hypertonic saline. Let's find out how these work. So lignocaine we know is class 1B antiarrhythmic. They have a special feature. They act on sodium channels when they are inactivated. So what they do is they replace the tricyclic antidepressants because they also act on the fast sodium channels. They replace them. They decrease the conduction as these are the only antiarrhythmics which will decrease the action potential duration. So they will narrow your QRS complex and may help in reducing the arrhythmias and improve hemodynamics. Another option, 3% NaCl. Here, the simple logic or theory behind is if you give a lot of sodium, you create a sodium concentration which will enter and overcome the tricyclic antidepressant induced sodium channel blocking agent. But then still, why they are still under controversy, they are not used as first line in tricyclic antidepressants. For 3% NaCl, I'm sure you all know it is hypertonic. We do not want to cause more problems, other problems than the one we already have at hand. Secondly, there are not many studies done on humans with tricyclic antidepressant overdose with using 3% NaCl as the first line or second line. For lignocaine, the problem is they reduce the seizure threshold of a particular patient, and this patient is prone to seizure because of tricyclic antidepressants. However, both these drugs have been used in certain case reports and scenarios, but they are not yet used regularly. For seizures, it's important that we give benzodiazepines first line. If the patient is having refractory arrest or refractory arrhythmias, not responding to any of these, sodium bicarbonate or our vasopressors, or after we have tried everything, then we can consider lipid emulsion or your ECMO. If we are giving lipid emulsion, we have to give to 20%, 1.5 ml per kg bolus over 2 to 3 minutes, followed by 0.25 ml per kg per minute to a total of 10 ml per kg. This dose is similar to everywhere else where you're using lipid emulsion. Again, its lipid emulsion has a role because tricyclic antidepressants are highly lipophilic. So again, theoretically, lipid emulsion will act as the sink, and tricyclic antidepressant overdose may be dealt with this if the patient is refractory to the drugs given before. Whenever we are giving sodium bicarbonate, we need to follow certain check steps so that we do not cause complications. First is always to rule out hypokalemia, because when you administer sodium bicarbonate, the patient will eventually develop hypokalemia. So you first correct the potassium if it is already low. If it is not low, during the course of treatment, potassium has to be replaced. Then we give the initial bolus of 1 to 2 milliequivalent per kg of 8.4% sodium bicarbonate over 2 to 3 minutes or 1 to 2 minutes. We recheck the ECG. See, it's important that ECG here is also acting like our monitoring for treatment. So we repeat the ECG and we look whether the QRS duration is shortening or not. So if the QRS is still wide, then we continue the infusion at 150 milli equivalent uh, in 1 liter D5 and run it at 2 to 3 ml per kg per hour. And we continuously keep on doing serial ECGs. We check for the pH. It is mentioned everywhere that the target pH is 7.5 to 7.55, but it's not the pH that we should be targeting. The endpoint for treatment is the narrowing of QRS complex. We have to maintain the pH between 7.5 to 7.55. For managing seizures, benzodiazepines are the first line. If the patient does not respond to benzodiazepines, we directly move to phenobarbital. We do not give phenytoin in these patients because phenytoin also acts on sodium channel and it will worsen the sodium channel blocking action of tricyclic antidepressants. So we are trying to treat seizure, but we are worsening the cardiac toxicity. So then as for all seizure patients, we need to correct hypoxia and acidemia. And we also need to avoid physostigmine. See, these patients will come to us with features of, they may come to us with features of anticholinergic toxidrome. And you may consider, okay, all features are present. What is the antidote? Physostigmine. Let's give physostigmine. But if we give physostigmine here, what will happen is, again, this may precipitate cardiac AV blocks, or it may also reduce the seizure threshold. So this can lead to patient deteriorating very, very fast. If the patient presents to us in hypotension, our first line is crystalloid fluids. Then, as we discussed, sodium bicarbonate. If the patient is still refractory to both the treatment by sodium bicarbonate and the fluid bolus, then we start with norepinephrine. We can also consider adrenaline. Dopamine is usually avoided because of the arrhythmia risk. For enhanced elimination, I would like you to tell me whether there is a role or not. I am giving you the properties of tricyclic antidepressants. So they are highly protein bound. They have a large volume of distribution, and the elimination is almost entirely by hepatic oxidation. So can you just type in the chat box whether there is a role or not, all those who are attending? What do you think? Yeah, so I am getting responses, and you're right that there isn't any role because we are getting so many problems with dialyzing the toxin out of the system. None of these will actually help us in, none of these are characters which will allow enhanced elimination. Another important aspect here is because of this hepatic oxidation, some of the tertiary tricyclic antidepressants will produce active metabolites after hepatic oxidation, and your duration of effect will be longer because of this. So their effect may be longer. This is something to remember. We monitor the cardiac monitor, we look for the ECG serially, and the patients to be observed for 6 hours. If the patient has to develop any features of tricyclic antidepressant toxicity, they will develop it within 6 hours. Beyond 6 hours, it will not take. for a patient to develop the features of TCA overdose or toxicity. For disposition, it's the criterias are simple. If the patient had presented with arrhythmia or seizure or hemodynamic instability, the patient needs admission. If the patient had just a QRS duration of 100, more than 100 milliseconds or had altered mental status, we start with monitoring the patient, and then as the patient situation changes, we make a decision on disposition. If the patient is well at 6 hours, we can medically discharge this patient if the psychiatric team clears the patient. This is one thing which ED physicians forget, that psychiatric evaluation is also important whenever we are dealing with toxicity. Some other cardiac toxins which have to be differentiated. If we are just looking at the ECG and we are finding the patient is hypotensive and we know that the patient has taken some drugs, then there are a few cardiac toxins we have to keep in mind along with tricyclic antidepressants. That will be your beta blockers, calcium channel blockers, and your cardiac glycosides. They have their own specific features. So you can look at tricyclic antidepressants. We know it's wide QRS. For digoxin, you will find this ST depression, scoot. Then your shortened QT, find a flattened T wave, presence of U wave. For beta blockers and calcium channel blockers, you may predominantly find bradycardia or slow conduction blocks you may find in these patients. However, they will have a narrow QRS. In calcium channel blocker overdose, in addition to this, you may find hyperglycemia, but it's not necessary that all patients have hyperglycemia. With this, we come towards the end of the session. It's important that we remember that the levels per se also are not enough to tell us about the severity. As we discussed, that these are highly lipophilic, have a large volume of distribution. So the blood levels will never actually tell you how much tricyclic antidepressant is truly in the body. Some are there up to 100, 100 times than what the level is showing in the blood. So it can help you guide therapy, but it cannot therapy in normal therapeutic roles that tricyclic antidepressant have, because they have a narrow therapeutic index, but not in overdose. We avoid physiostigmine, as I said. They can precipitate asystole, they can increase the seizure threshold. ECG stays the mainstay of diagnosing these patients and even acts as one of the endpoint targets for management. We avoid all other arrhythmics actually for managing arrhythmia in these patients. Sodium bicarbonate stays our first choice. We do not restrain these patients because hyperthermia can uh, be worsened by the struggle of these patients. So with this, we come back to the patient we had seen earlier. I'm sure we all diagnosed it with TC overdose. You can just go through whether you diagnose the toxidrome right. This patient had a clear-cut anticholinergic toxidrome. If you look at the ECG, the patient had QRS wide, patient was tachycardic, and there is a terminal R wave. I'm sure QTC cannot be calculated from this image. Um, Next, we had discussed which ECG findings will predict seizures. That is your QRS duration of more than 100 milliseconds and QRS duration of more than 160 milliseconds predicts ventricular arrhythmias. Investigations we are sending, usually all of these are routine investigations that we are sending for all patients. As this was a female patient, it was important to check for her pregnancy status also, because of medical legal effects and because we need to consider about the baby, if fetus, if there is any. Management mostly remains supportive along with bicarbonate. Drug of choice for QRS widening in these patients will be bicarbonate, and the endpoints of therapy we discussed. I hope that this was a session which was useful to every one of you. And in addition to the sources mentioned in each of the slides, my references of textbooks are listed here. If you have any questions, we are open for a discussion. So if you cannot remember or cannot ask right now, you can email it to me.
Ma'am,
Yes.
what are the steps that we can take if, say, per se, we are infusing soda bicarb infusion and we have to maintain the pH uh, uh, in a range, and say the patient is having uh, like more basic in nature, like pH crosses the base limit. So what should we do for that?
So see, we do not have to do much about, decreasing the basic base. You're saying that if it crosses 7.55, that's your question, right?
Yes, ma'am. Yes,
So
ma'am.
if it crosses 7, firstly, these patients are usually acidic. They will not be basic. The blood gas will not be basic. So to reach that level also will take some time. But in case you do cross that level, we have to remember that 7.6 and beyond is your difficult to sustain with life. So as long as that is not reaching, we do not need to essentially stop sodium bicarbonate. But if that is happening, then we have to consider our second line drugs and consider holding sodium bicarbonate also. That is why those second, third line options are there for us. When we are talking about refractory conditions, patient not responding to sodium bicarbonate, even this category of patients will fall there, where you may have to consider lipid emulsion, you may have to consider ECMO, you may have to consider other arrhythmics. You cannot actually give anything else to reduce the bicarbonate, the basic nature of the blood gas.
Thank you, ma'am.
Thank you. So if there are no further questions, we can close the session. If you remember any questions later or you have any doubts further, the group is there and my email address is here. I hope we learned something today. Thank you for this opportunity.
Thank you. Thank you so much, ma'am. Thank you for sparing 1 hour for us. And it was a lovely lecture, and it was a pleasure listening to you after a long time. And
Thank you.
thank you for the lecture. Yes, we will see everyone in another lecture in coming 2 or 3 days. And thank you everyone for joining. Thank you.